What is this mammogram and what is the evidence behind this mammogram? The first real prospective randomized control trial that was done was the health insurance plan study to see whether this mammogram helps in reducing the death from breast cancer. So what did it conclude? It said that it reduces breast cancer mortality by 30% about 10 years after the study was started. Now, after a period of 18 years of follow-up, those in the screening arm had a 25% lower breast cancer mortality rate. So this is the most important study based on which we are able to now recommend mammogram as a screening tool for breast cancer. Now, what is the role for the clinical breast examination and self breast examination? Yes, there is a role, but it may not be able to give the benefit that we anticipate in terms of reducing the mortality. You will be able to pick it up, you will be able to treat earlier, but it is not statistically significant for you to reduce the mortality. And that is the reason why mammogram is recommended as the single most important tool for screening assessment for asymptomatic women. The current consensus is screening women 40 to 75 years of age, it does reduce the relative risk of breast cancer death. And the overdiagnosis does exist, and it is estimated to be about 11% to 19% of breast cancers diagnosed by screening. That means if you detect 100 cases of breast cancer by screening on asymptomatic women, about 10 to 20%, that is 11 to 19% to be precise, that is 1/10 to 1/5 of them, maybe you are picking up the overdiagnosis. So that is an issue that has to be kept in mind. But keep in mind that you are going to be picking up 80 to 90% of women earlier, and you're going to give them mortality reduction. So overall, as a community tool, it is very, very effective. The women with 40 to 49 years who may not benefit much from screening mammogram is when there is a dense breast. So women with dense breast, it may not be a very good tool. And there is something called as interval cancers. What is this interval cancer? For example, a lady undergoes a mammogram every January. Suppose she 2020, she had a mammogram, normal. 21, she had a mammogram, normal. 22, normal. 23, she has a mammogram. Okay. That time, you are picking it as normal. April, she has pain. We are in March. Today, we are in April, right? Yeah. She undergoes a mammogram. That time she picks up a lesion. That becomes a screening interval detected cancer. So a screening cancer, that is an interval cancer, is between two mammogram screening done every year, you do for some other reason and pick up a cancer. This is called as an interval cancer. An interval cancer means between the period she is developing a cancer. That means it's a very fast growing tumor and they have a poor prognosis. So this is what we call as an interval cancer. So mammogram is not without risk. Okay, a typical screening mammogram normally has 4 millisieverts radiation exposure. So you can estimate that an annual mammography will cause up to 1 breast cancer for 1,000 women screened for age 40 to 80 years. Okay, so somebody who is going to undergo mammograms so many times, 1 breast cancer can happen in 1,000 women. So it is not something without any risk. Yes, it is there. But now we should understand that the newer modalities that have come, the radiation exposure is going down lesser and lesser. So probably we may have get to at some point of time where this risk may be a lot more lesser in the later age group. And you should keep in mind that radiation due to mammogram may cancers in more commonly in BRCA mutated women. So this is something that you have to keep in mind. Okay, next slide, please. Now, I see some questions that are coming up in the webinar chat. I will finish the lecture and definitely answer all your questions. Please keep the chat going. I will come back to all the questions on the webinar chat at the end of the program. I have kept it in mind that I will have enough time to spend with you once the talk itself is over. Now, we should also understand certain terminologies. We always talk about breast imaging, then you should know what is a BIRADS criteria. BIRADS refers to breast imaging reporting and data system. So this is the reason, because if radiologists all over the world report in their own language, then we will not know which is the suspicious lump and which is not. But if the same language, by language I mean the same terminology is used all over the world, then it becomes very easy to interpret, and this is why this system came into view. So category 0, that is, it means there is a need for additional imaging or prior examination. So such a patient we have to recall and get an additional examination done or an additional imaging done. A category 1 is a negative Virat's recommendation. That means the patient can have a routine screening and essentially the patient does not have anything to worry about. A benign patient, category 2, will again have a routine screening and essentially likelihood of cancer is essentially very low. Probably benign, the short interval follow-up, that is, we recommend the follow-up period of about 6 months or a continuous follow-up. It is slightly higher than compared to a benign one, but not as much as a suspicious lump. So what happens in a category 4 suspicious lump? We recommendation is do a tissue diagnosis. So low suspicious of malignancy is when the risk is between 2 to 10%. Moderate suspicion is 4B, when the risk is between 10 to 50%. And 4C is a highly suspicious for malignancy when the risk is about 50 to 95%. And highly suggestive of malignancy is when you have a tissue diagnosis recommended and the risk is more than 95%. And in the known biopsy proven case, the surgical excision or a clinically appropriate treatment should be recommended. So this Birat's reporting has essentially removed all the ambiguity. Rather than somebody saying highly suspicious, low suspicious, here we have set rules and set numbers. So you can compare anywhere in the world, and this is why this Birat's reporting is very, very important. Next slide, please. Okay. Now, what do we do for high-risk screening? Till now, we were discussing all about asymptomatic women. Asymptomatic women, the recommendation is less than 40 years, no screening tool. More than 40 years, we recommend mammogram. Oh, what about high-risk individuals? For high-risk individual, we mean somebody like a BRCA mutation positive, a first-degree relative with a BRCA mutation, or they have other high-risk cancer syndromes like Peutz-Jeghers syndrome, Cowden syndrome, Lee-Fraumeni, ataxia telangiectasia. All these patients become a high-risk individuals. A lady who's been treated with radiation to the chest for Hodgkin's disease in her childhood or in her adolescence again becomes a high-risk individual. All these patients we recommend screening with an annual MRI from the age of 30 years. Why do we recommend this? This is because they have a greater lifetime risk of breast cancer is about 20 to 25%. This is based on various cancer risk estimation models. So this is the ACR guidelines for doing a screening annual MRI. Now we move on to the next cancer. We talked all along about breast cancer screening. We move on to colon cancer screening. You should keep in mind that of all the screening methodologies in place, if there is one or two very, very important screening tools that have made a significant decrease in mortality, that has to be with regards to colon cancer and cancer cervix. Because there you have such a long period of the lead time. So you have a good time to do interventions where you can knock out the cancer within the in situ stage, leading to a higher risk of, a higher chance of survival. So this is because the adenoma carcinoma sequence, we call about an adenoma carcinoma sequence for a colon cancer. Usually the colonic tumor start as an adenoma, progress on to develop into a carcinoma. This takes about 10 to 15 years. The minimum time that is required for an adenoma to develop into a cancer is at least 5 years. So we have enough time. If you pick it up as an adenoma by doing a polypectomy or adenoma removal, you are reducing the risk of the person developing a cancer. So this is a very, very useful cancer to screen. Endoscopic polypectomies reduce the incidence of colorectal cancer by about 20%. And we know that flexible sigmoidoscopes have demonstrated a 23% reduction in the colorectal cancer incidence and a 31% reduction in colorectal cancer mortality after a median of 11.2 years. So flexible sigmoidoscopies can find 60 to 80% of cancers and polyps that are found compared to a colonoscopy. Flexible sigmoidoscopy is a very easy procedure to do compared to a complete colonoscopy, which requires some form of sedation and all these stuff. So what do we do for colorectal cancer? We screen at the age of 50 years. The tools that are available are annual high sensitivity fecal occult blood test or a fecal immunochemical test. It reacts only to human hemoglobin, and now we have even fecal DNA tester coming up. So, like a woman does pregnancy testing with on a urinary dipstick, similarly, you have these test kits that are available that a patient or a person can go into the restroom, take a bit of the test screening with a fecal occult blood testing, and they will know whether this sensitivity with a very sensitive tool, you will be able to know whether there is a FOBT positive or not. A simple FOBT is a very useful tool to prevent, is a very useful tool to screen for colorectal cancer. But you have to keep in mind that this is not a test without any false negativity. Reason is it's a very high sensitive test, but specificity is low. Somebody on animal, somebody on meat, for example, somebody who's taken meat previous day, 2-3 days, they may react false positive. Reducing sugars in the diet again may become false positive. Somebody who's taken a beetroot consumption 2-3 days before, they can also test positive. So all this has to be eliminated before we conclude that a FOBT test is positive. The other sensitive tools that we have is a flexible sigmoidoscopy done every 5 years once, a complete colonoscopy done once in every 10 years, a double contrast barium enema done every 5 years, or a CT colonography. CT colonography is also referred to as a virtual colonoscopy. Okay, basically it's a CT scan. With a CT scan, we get a reconstructed images like a CT colonography. So what is the recommendation? Adults more than 50 years screen once in every 5 years with a sigmoidoscopy, and adults between, the recommendation from the American group is 50 to 75 years every 5 years in combination with fecal occult blood testing, and the recommendation is category A. It's extremely useful to reduce the mortality. And more than 75 years, the recommendation becomes a little less strong. That is category C, and more than 85 years, the recommendation is not to do it. Colonoscopy, again, more than 50 years, screen once every 10 years. The recommendation is 50 to 75 years. If you have to do a screening colonoscopy, do it once in every 10 years. So this is the US Preventive Task Force recommendation for colorectal cancer. Next slide, please. Lavanya, can I have the next slide, please? Okay, what do we do for familial or people with inherited risk of higher risk of colorectal cancer? Okay, so a family member, the first degree relative affected with the colorectal cancer, or an adenomatous polyp at the age more than 60 years, or 2 second degree relatives affected with colorectal cancer, it is the same as average risk, but you should start a little early. Instead of 50 years, you will start at 40 years. Instead of 45 years, you start at 40 years. Suppose the risk is higher, 2 or more first degree relatives with colon cancer, or a single first degree relative with colon cancer, or a polyp which is diagnosed below the age of 60 years. In this situation, you will do a colonoscopy every 5 years, not every 10 years, but starting at 40, you will do it once every 5 years, or 10 years younger than the earliest diagnosed in the family. So the family member was diagnosed at 48, then you will, 58 for example, you will have to start at 48 at least, whichever comes first. 40 comes first, we'll start at 40. If it is 38, then we will start at 38. So this is the risk stratification that we do. If it is a genetic carrier at high risk for FAP, then we suggest a sigmoidoscopy annually beginning at the age of 10 to 12 years. If it is a genetic carrier at risk of HNPCC, we start recommending a colonoscopy every 1 to 2 years, beginning at 20 to 25 years. So as you can see, in families with higher risk of colorectal cancer, recommendation is slightly more complicated depending on what is the risk. If it's an FAP, you know it's most often in the rectosigmoid. Without rectosigmoidal polyps, we don't get right-sided polyps. So a colonoscopy not necessary, but a sigmoidoscopy is sufficient, but you have to start at 10 to 12 years. Whereas in HNPCC, where right side colon cancers are much more common, you have to do a complete colonoscopy, and the age group that you start is about at 20 to 25 years. Next slide, please. Going on to cancer cervix. Cancer cervix still date in India is the second most common cancer. In rural population, still cervical cancer is a very, very highly common disease, and we have a very efficient tool to pick it up. That is what we call as the pap staining or the pap smear. you can do it in two ways, either the conventional cytology or a liquid-based cytology. Conventional cytology is easier to do because it is available in much larger areas. But if you look at the gold standard, it will be called as the liquid-based cytology because it is much more reliable. And the fact that you can do a HPV DNA testing also in it means that a conventional is less efficient compared to a liquid-based cytology. Next slide, please. So what is the recommendation? The recommendation is women between 30 to 65 years, acceptable approach to screen with cytology every 3 years. And this is the PAP testing. So recommendation is 30 to 65 years, the screen with the cytology, that is with the liquid-based cytology, once every 3 years. And women, the recommendation from ACS guideline is start earliest 21 and screen once every 3 years. So this is a slight difference between the two groups, the United, the task force and the ACS guidelines. If you look at HPV testing, again the recommendation is screen with HPV and cytology once every 5 years. That is the task force recommendation. Whereas the ACS guideline says 30 to 65 years, screen in combination with cytology every 5 years if a woman desires to lengthen the screening interval. So this is the slight difference that we find with regards to the cancer cervix screening, whether we are doing only the PAP test or we are doing PAP with the HPV testing.